Oh, okay. Okay, here we go. Hey everyone, it's your friendly neighborhood scientist here, and welcome back to my channel. Today, I am so excited because if you did not know, April is actually Donate Life Month. And I am so honored today to have Dr. Silas Norman here with me. He is the co-medical director of kidney and pancreas transplantation at Michigan Medicine's Transplant Center. So please give Silas a warm welcome.
Thank you.
Insert applause and confetti and all that good stuff that I don't have. But yeah, thank you for being here with me today, Silas. I appreciate you taking time out of your day to come talk to me and the community about the prevalence of kidney disease in the African American community, as well as kidney and pancreas transplantation.
Thank you. I appreciate the invitation and the opportunity to talk on these important topics.
Great, great. So before we get started, just, to my hood scientists out there, let me say we are not here to diagnose, treat, or recommend treatment for any condition. This is for informational and inspirational purposes only. For any information that you think is relevant to you or relevant to something you want to learn more about, please, please, please go to your doctor. AKA, don't come on here talking about what you didn't heard on your friendly neighborhood scientist and you didn't went out there and did nothing. We ain't told you to do that, so go on to your doctor, okay? Okay, that's number one. Let's get that out the way. Number two is, this topic is really, really special to me, so I am dedicating it to an aunt and uncle and a cousin who passed away from kidney complications, as well as an aunt who gave the selfless gift of being a living donor. I also have other family and friends who either have kidney transplants or actually have kidney disease. So this one is for you all, okay? So we got all that. Now let's start. Now, first, what made you not only be a physician, but in particular, a nephrologist?
So, no, it's a great question. My father was a physician, an internal medicine physician, and I grew up in Detroit. And, growing up in Detroit, I certainly recognized, even though I didn't understand it, that there was a lot of medical disease in our community, had an interest in trying to help treat that disease in our community, and really thought I was going to be a general practitioner like my father. And then during my training, I had the opportunity to really meet some fantastic nephrologists and came to understand the prevalence of kidney disease that we have in our community, and then one thing led to another, and with their influence, came to study kidney disease. And then I was fortunate when I came to University of Michigan to meet a physician, Dr. Ojo, who was one of the transplant physicians. He was my research mentor, and so here I am in transplant, and I think everything works out the way it was meant to be.
Oh, well, you know what? Ironic, the people and the patients who have went to you, they really just rave about you. So thank you for doing this important work.
Thank you.
When we talk about kidney disease, right? What does that mean? Does it just mean like a disease of the kidneys, or can it encompass other things?
No, it's a great question. So everybody has two kidneys, and the kidneys are primarily involved in your water balance, getting rid of excess water or holding on to water, and getting rid of waste products, metabolic waste products from the food you eat and just regular life processes. And when those things break down, people tend to get swelling, and they get accumulation of these waste products that can make people sick in a number of ways. Some people have their kidney disease because they really have something specifically wrong with their kidney and their kidney only, but most people have their kidney disease because they have some other systemic disease, like diabetes or high blood pressure, that's affecting lots of parts of their body, including their kidneys.
Okay. Fun fact, just a few years ago, I found out that kidney transplants are they put in the stomach?
They are.
I had no idea.
And you know, it's interesting, and that turns out to be really a practical move, because our original two kidneys that we have are on our flanks. And when we take a donor kidney, either from a living donor or a deceased donor, we have to cut the drainage tube from the kidney to the bladder a little shorter. And so for many people, if we tried to remove one of the original kidneys and put the transplant kidney in the same place, it just physically wouldn't reach the bladder. And so as a practical matter, we leave the two original kidneys in, and we go up front, low in the pelvis to put the kidney in. We sew the transplant kidney in separate from the two original kidneys into the bladder. And then we use the blood flow that goes down people's legs on one side or the other to tee in the blood flow for the transplant.
You can tell you an expert because you just ran that down like, okay. And you know, so when you say the flank, of course, so the flank is the sides of our bodies, right?
On
like
the sides,
of course, the back, kind of the sides.
Exactly.
And when you said that, I mean, I don't know if this is morbid or not, but I have some flank steak marinated right now, and it kind of turned my stomach a little bit. We're making street tacos tomorrow, and we have it marinated. And I'm like, yeah. Anyway, okay.
Makes you think about it a little bit.
I mean, yeah, just a little bit. Like, okay, all right. So I'm eating the flank of a cow. Okay, all right. Yeah. So, and it's gonna be good, and I'm not ashamed of it. Okay, I'm not ashamed. So can kidney disease be hereditary?
It can. There are some diseases, probably most notably polycystic kidney disease, that's an inherited disease. And many people, may find they have multiple people in their family with it. It can be directly inherited. And then we find what we call more familial disease, where with high blood pressure, for instance, we may find that a number of people in the family have high blood pressure, probably from a combination of some genetic reasons, from some lifestyle reasons, similar with diabetes, where we often, that family history can often be very important.
Okay. And so people who have kidney disease, and correct me if I'm wrong, some people can live with, stage maybe 1 or 2, and that would mean that they are not on dialysis. But when it gets to a critical level, then they go on dialysis. Is that correct?
Correct. So we often talk about kidney disease, as you mentioned, in terms of stages, from 1 to 5, with 1 being the least severe, 5 being essentially kidney failure. And there are a lot of people who have kidney disease, stage 1, stage 2, stage 3, who might not progress to needing dialysis or a transplant ever.
Okay.
And that's terrific. Now, one of the things, though, when people are in stage 1, 2, 3 kidney disease, and perhaps as much as we think about dialysis and transplant in relation to kidney disease as the consequences, what's really important to know is that the major cause of death in people who have kidney disease is really cardiovascular death. It's excess heart attacks and strokes.
Really?
And so, absolutely. And so even for those folks in stage 3 kidney disease, in some sense, we're less worried about their chances of progressing to dialysis than the fact that they need management because they're at increased risk of having heart attacks and strokes. And in some sense, that's really what we need to manage to make sure that people do well.
I had no No idea that the risk was higher for cardiovascular and strokes versus like dialysis for people who are like stage 1 or 2 or that's interesting. And so dialysis, it filters or cleans your blood, right?
It does.
Okay.
It does. And so dialysis, we talked about how the kidneys are supposed to clear waste products from your body, and they're supposed to manage your fluid status. When you get into kidney failure from one of these diseases and you can't do that yourself, dialysis is an alternative. And with dialysis, essentially one of two ways, takes blood out, we call it cleans the blood, gets rid of the waste products, can get rid of excess water if we need to, and gives people back clean blood if they're doing hemodialysis. And so it's in some ways it's really a technological revolution in some ways to allow people to live for years in ways that as early as the 60s this really wasn't a practical option. So as much as we take it for granted and for all its limitations, it's really relatively new.
Really?
Do this. Yeah.
I didn't know that either. So can people live on dialysis forever?
So
nobody lives forever. Clearly. But can there be like long-term function on long-term dialysis?
There can, but that's a great question because it's really a two-part question and it's a yes and no question. Yes, people can. Yes, dialysis is life-saving compared to kidney failure with no treatment. Yes, people can be on dialysis for years successfully, but going back to this increased risk of cardiovascular disease, that risk doesn't change when you're on dialysis. If anything, that risk is higher when people are on dialysis. So for instance, if you take young people, someone who's say 20, who has to start dialysis, we know that in the general population, if you're 20, you should have a life expectancy, that's another 60 years or so, right? We expect you to live into your late 70s, mid 80s. 20-year-olds who are on dialysis have a life expectancy somewhere around 17, 18 years. And so it's a dramatic reduction in life expectancy. But I mention that because it can give people the illusion that you put, a 20-year-old on dialysis and 5 years later they're doing well. 10 years later they're doing well, but they're really not, because they have a life expectancy that's less than 40. And so even though people technically can be on dialysis for quite some time, I think this is why kidney transplant in particular, if we can't prevent disease in the first place, is important, because for most people, kidney transplant is associated with a substantial improvement in life expectancy compared to being on dialysis.
Right, for an extended period of time. Yeah. Okay, so I didn't know that either. So we were talking about prevention. You mentioned, first, right, the prevention. So why is kidney disease so prevalent in the African American community? It seems like African Americans have a higher instance of kidney disease, but then the weight on for an organ for African Americans, if they're listed for like a kidney, is significantly higher than other races. So why is it so prevalent in our community, A, and then B, why do African Americans have such a high weight?
Yeah. So when we think about kidney disease, every year a little more than 100,000 people develop kidney disease advanced enough to require dialysis or a transplant. And currently in the US, there's some 600,000 people who either are on dialysis or have a transplant currently. When we think about kidney disease, there are two major causes of kidney disease in this country. Diabetes, which accounts for about 45% of all the people who have kidney disease or on dialysis are from diabetes. And another just over 25% or so are from high blood pressure. So you can account for almost 3 out of 4 cases, almost 7 out of 10 cases of kidney disease, really with two diseases, diabetes and high blood pressure. And African Americans and some other communities have an excess of diabetes and an excess of high blood pressure. And the reasons for that, I think, particularly as we think about prevention, are very important to understand. We talked a little bit about, are there genetic kidney diseases? And what I'll say is that largely this is not related to genetic differences, although there are some genetic issues that are worth thinking about. When we think about diabetes and high blood pressure, in many ways these are lifestyle or life circumstance diseases. And that is to say, if we think about maintaining a healthy body weight and being active as the two main ways to minimize the chances of having diabetes and high blood pressure. And then that makes us back up a step and say, well, okay, what do we need to do to maintain a healthy diet? And we know, as I mentioned, I'm from Detroit originally. We know that Detroit is one of the that's West Side.
Oh.
So,
okay.
So,
sorry. Anytime somebody say Detroit, you gotta throw up the what up though, and you responded with the appropriate response.
We can talk about high schools in a little bit. But
that's another hood science.
That's
discussion.
that might be a whole. I don't want to sidetrack the conversation. So from Detroit, so then that Detroit is one of many cities that would be considered a relative food desert.
Right.
So we talk to people about having a healthy diet, but we know until very recently there were no major chain grocery stores in the city of Detroit.
Exactly.
And so the idea of just telling people to eat healthy is not as easy as it seems. We know that a lot of this, in addition, then overlaps people's economic needs. And we know that Detroit, we know the African community in general is a relatively impoverished economic community for a number of reasons. And that again limits access to healthy food. So we have challenges on that end. We talk about maintaining regular activity. Again, there are some areas, that where people just don't feel safe. Walking outside regularly. Don't have a park. And so there's challenges there. Again, going back to the economics, not everybody can just join a gym, and run. So we have those challenges. Compounding that, we know we have an excess of obesity. Really, in some sense, as a consequence of other issues, and obesity directly increases the risk of diabetes and high blood pressure. And then, so with those being the leading causes, we have excess diabetes and high blood pressure. So we have excess kidney disease. You mentioned that a lot of people in early stages might not progress. Often, though, to not progress usually requires recognition that you have the disease and access to healthcare to manage it.
Listen, so everything you are saying, all that's flashing in my head is disparities. Barriers to access, no access, and it is. The more that we have these conversations, and the more that I have these conversations with different subject matter experts, that's the number one common theme, is the disparities between people in underrepresented communities and access to healthcare, to healthy foods, and so that is just, to me now. And also let me say it's a cultural thing too, because when you say diabetes, that's AKA the sugar, right? That's what my grandma said. That's the sugar, So we talk about the sugars. And I was raised, I'm not from the South, but some of my family is from the South, and my father is was born in Chicago. But I was raised, whatever you eat, you need to eat it from the rooter to the tutor. That's what I was taught. Yeah. Right. So that's what grandma said. Don't waste nothing. And it's amazing how when we even think about diet, about how it's rooted in traditions, right? They even go back to slave days. Even things like oxtails. I love a good, I love a good oxtail. Okay, I am country. I am super duper country. But I didn't know that oxtails were, it was considered slop, right? And it was given out, thrown out to the slaves. And, our ancestors made it into a delicious meal. And now oxtails about $25 a pack at the grocery store, So I think too is like reconciling the cultural history and implications that I think help us feel like we're connected as a community and as a culture, but also understanding, like you were saying, some of those things are not healthy for us in the long run.
Absolutely. And no, that's a great point as you link it to that history, realizing that that we were eating a lot of foods, making things, not really by choice, but because this is what we had available, in a resource restricted time period. We made something out of it, but bringing it forward then to, 2021, what we're eating, the amount we're eating, the density of the food that we're eating, combined with just the differences in the physical activity that we were doing throughout most of history until the Industrial Revolution, compared to now is just different.
It is. And when you talk about diet, someone told me they were on a renal diet. What does that mean?
So when your kidney can't get rid of a number of these waste products, there's some of these waste products are common things that are in food, things that are usually good if you have good kidney function. Things like potassium, which has some heart benefits. Things like phosphorus, which can be good for your bones. But when you have kidney failure, you get excess amounts of these things building up because you can't get rid of them. And then what that requires then is in your diet that you eat a diet that has very little potassium in it, that you eat a diet that has less phosphorus in it, because your kidneys just aren't able to get rid of it.
Got you. But so then that goes back to disparities, because if, you were talking about how that was a resource restricted time, like back in the slave days, but then still it seems resource restricted in ways like having a food desert where you can't necessarily get to, or there isn't, somewhere close by where you can possibly get healthy foods and things like that. So the disparities are just, I think, being magnified the more we have these authentic and transparent conversations,
No, I think that's absolutely correct. And I think, if there was, among the messages, I think one of the most important things as people think about trying to manage their health, take control of their health, really is this shift of understanding. We put a lot on ourselves in thinking about how it is our responsibility to manage our health, and in some sense it comes down to thinking about it as our willpower or desire to do this. But really, I think it's important for us to appreciate the structural inequities, the structural barriers that are out there to health for Americans in general, and certainly for Black Americans. So we really don't, as you said, that realize that we are trying to be healthy, within a context that has made us unhealthy. Resource limited, living in areas with, more pollution, living, limited transportation, the food deserts, this makes it complicated. And so, we should, in some sense, give ourselves a little bit of a break as we work to manage our health and realize that, were we in a different circumstance, we would likely be healthier.
Exactly. Right? That's a very significant point, though, to give ourselves a break, right? Let this be a hood science mental health moment. Give yourself a break. I think we're all super critical. I mean, I'm my worst critic. I think we are the hardest on ourselves. So I think that's very important to recognize as well. So we have the kidney disease. Now we're talking about kidney transplantation. So, and again, April is Donate Life Month, which is everything and anything about organ transplantation. So the kidney transplant process, right?
Yeah.
People who are listed for, or who want to inquire about getting a transplant, they have to go through certain testing and things like that. How can socioeconomic disparities impact the ability of people from underrepresented communities getting listed for kidney transplants?
Yeah. So as we talked about a little bit, one of the limitations when people are resource limited is access to quality health care. And when you are trying to move somebody towards getting a kidney transplant, typically these are going to be people with advanced chronic kidney disease. And when we ideally move people to transplant, if possible, we'd like to get people transplanted when they have advanced kidney disease, but they're not yet on dialysis. To ideally avoid that in the first place.
Right. Okay.
And sort of in the same way as you'd like to replace your car before it breaks down, right?
Right.
But to do that requires that people are aware they have disease.
Right.
That they know what stage of disease they have.
Right.
That they are able to get referred to a transplant center in a timely manner.
Okay.
And we know that there are delays for African Americans and other people of color all along that spectrum. And then once referred for a transplant evaluation, there's a lot of steps between the evaluation to complete that evaluation and move to transplant. Often, some of those things we ask of people in moving them towards transplant are going to be things like, can you reliably get to the transplant center? Do you have a backup driver? Who's going to be your support? Do you have a backup support? Do you have a second backup support? Sometimes you have a third backup support. And if you, again, it goes back to these resources. If you are asking those questions, which on the face of it make perfect sense to make sure that people are, successful as possible, again, going back to Detroit, we know, some half of folks in Detroit were driving, without insurance because of the cost, right?
Yeah.
And so if you have folks, a group that disproportionately has kidney disease and is resource limited, and you have a lot of requirements for transplant that really require resources. Right. You can have a backup support. So, my wife would be my backup support, but if you want a second backup support, and even with my wife, often we're talking about who do you have in your life who could not be at work, at least once a week for several weeks. Most of us are not fortunate enough to, get paid when we're not at work. And so it becomes less about willingness than, ability. And so this can create, barriers to timely transplantation. And then as you mentioned, once we get people on the waiting list, we see that African Americans tend to wait longer for transplant.
Yeah, why?
And so a couple reasons. One is that we are overrepresented on the transplant waiting list in the same way as we are overrepresented among folks with disease, and
Right.
so we make up about, 13% or so of the general population. We make up about 35% of people on the transplant waiting list. So we're,
That's
and it's significant, right? And it goes back to that excess of diabetes and high blood pressure. African Americans have about 3.5 times the risk of developing kidney disease as our white counterparts, and so not insignificant. So there's a lot of us on the waiting list, and then it comes down to some of the requirements and some of the things that we've made decisions about on the waiting list. We know we need compatible blood types for transplant to work. And then we get into some of these little quirks that it turns out, in a way that only matters for transplant, about 10% of the population has a B blood type. Interesting, neither here nor there. It happens that African Americans, about 20% of us have a B blood type. Again, interesting. But if you combine the fact that we're twice as likely to have a B blood type and we're overrepresented on the waiting list, that means that there's an overrepresentation, for instance, of people with a B blood type on the waiting list. And that means that people with a B blood type tend to wait longer because there's more people waiting. And those folks are disproportionately Black. And then in the past, although it's been undone a little bit, we had some rules about how we match organs. And because about 70% of the donor population is white, it's pretty consistent with the representation in the population.
Oh, sorry, go ahead.
No, I was just to say particularly in the past, we put a lot of emphasis on matching of some proteins that are important, and not all these proteins. Some proteins are more prevalent in white populations or Black populations. And so when you put a heavy emphasis on this matching, what it meant was if you had a majority of white donors in excess of Black folks on the list who need kidneys, we were going to be less likely to have these better matches. And so we were going to be less likely to get transplanted.
So there's a science to it. There's a very, it seems, intricate science to it. And you talked about, so 70% of organ donors are other races other than African American or white. Why do you think the African American community may be underrepresented as far as even signing up to be an organ donor or even signing up to be a living donor?
Yeah. So I think, so that's a fantastic question because it actually, as you were talking about the concerns about transplant itself, gets at, I think, one of the real, in some senses, myths about transplantation, right? That Black people don't donate, right? When you look at donation, we have a country that's 65-70% white. It's about 13-14% Hispanic. It's about 13% Black, and then some additional ethnicities. When you look at who donates, overall donation looks just about like that. 65-70% of the people who donate are white. Overall about 13-14% of people who donate are Black. About 13-14% of people who donate are Hispanic, etc. Those numbers aren't exact, and there's like a little difference there, but people basically donate consistent with their representation in the population. And so it's not that African Americans don't donate. We do donate, just like everybody else. The catch is that, as we talked about, we are overrepresented in the need for transplant. And so even though we're only 13%, but 35% of us are on the waiting list. And so in some sense, the ask of African Americans is, can you donate more? You donate in excess of what other people are donating to meet this need.
Well, we only got 2 kidneys, child. How we gonna donate? What we gonna do?
Again, we're doing, and I think, right, and I think it's terribly important to that difference, right? Because because there's two different messages depending on what you think.
Right.
One message is, y'all don't donate.
Mm-hmm.
What do we need to do to convince y'all to donate?
Mm-hmm.
Right? And how come you're not stepping up? Right.
Mm-hmm.
And that's one conversation. But the other conversation is, oh, you are stepping up,
Mm-hmm.
but you have an increased need. And how can you do more? And that's a positive, in some sense, a positive, different conversation.
Exactly.
How come you're not doing what you need to be doing?
Exactly. Exactly.
And so we are, and there's certainly efforts in Michigan where with folks like Gift of Life Michigan and MOTEP, the Multicultural Organ Tissue Transplant Education Program, where registrations for African American donors in Michigan, a few years back was just under 20%.
Mm-hmm.
And again, African Americans are 14% of the Michigan population. And so we do donate, we have an excess need.
Mm-hmm.
For the second part of your question about living donation, why is there a dearth or a paucity of African American living kidney donors?
Mm-hmm.
I think comes back to largely two things. One was, we talked about, which is medical disease. We said our community has excess diabetes, excess high blood pressure, excess obesity. When we evaluate people as potential living donors, they need to not have diabetes, not have high blood pressure, not have risk factors for kidney disease, not have kidney disease. And so if you're dipping into a population where there's a high prevalence of
prevalent,
you're going to exclude a lot of people.
So you can't have, or you shouldn't. So let me rephrase this. So you, to be a living donor, you should be as healthy as you possibly can.
Absolutely, right?
Okay.
You need to be healthy, and you certainly, if you're going to give up one of your kidneys, we don't want you at higher risk of developing kidney disease.
Right? That is because then you only have one kidney.
And we don't want to put the donor at risk. And so we exclude a lot of people who are willing to donate, but they have diabetes, they have high blood pressure, they have kidney disease already. We, through the process of evaluation, find out that they have disease. So we exclude a lot of people. And we talked about this, some of this is familial. And so, if I have chronic kidney disease, from diabetes, and we know this through science, we know that we are likely to find in my family other people who have kidney disease from other problems. And so maybe I have brothers who want to donate, they have blood pressure, they have diabetes, they have this, that, and the other. So the second part, again, which we try to fix, but affects people, is if you're going to donate, you need to take time off for the evaluation, time off for the surgery. You're going to be off work for your recovery period, and we have a number of people who just can't afford.
So it's the resource issue again.
It's a resource issue, right? And there are certainly some programs in place to try to minimize that impact on people, financially, which have definitely helped to improve. But there's a number of people say, I can't not work for 6 weeks, and some people, even if we can cover the cost of that through some of these programs, may say, I may not have a job in 6 weeks. If I'm talking about, I'll be back in 6 weeks. And so again, resource limited, and that medical disease. It doesn't mean we don't try, doesn't mean we don't promote, doesn't mean we don't try to get people interested. I think the other thing is, and you brought it up, is the awareness of disease, right? One of the interesting things, because just like you, I have people in my own family, my own extended family, who have kidney disease, who've had transplant. And I think because the prevalence of disease is so high, we all know somebody who has kidney disease, whether we know it or not. But we don't know. Many of us don't know. Without that awareness, sort of the urgency for the need for donation, for the need to register as organ donors may not be there, because we may see this as some abstract thing that affects some people, not realizing that even if we're being, just thinking about our immediate family, people we know people who are in need, of this gift.
We definitely do. And like I said, I know I have some beloved family members who I miss severely who, passed away either prior to getting a kidney or after getting a kidney that actually failed, right?
Mm-hmm.
So,
Mm-hmm.
and I know, I have friends who have had kidney transplants. And so this really touches pretty much everyone's life. It seems that everyone can really relate or can know someone who suffers from this. So I'm hoping with the additional education and also encouraging people to take control of their health, to be proactive versus reactive, right?
Mm-hmm.
If there are things that we can do, not only as a people, but as a community to prevent disease, we really need to do it because it's for the greater good. Not only is it for your good and your family's good, but it is for our good as a culture. So
Absolutely.
Yeah. So, the big thing right now, of course, while we're on Zoom is COVID-19. I don't even like saying that. I just, go far away. I'm so sick of the Rona, Miss Rona. That's a whole nother hood science chat. But so we're in this COVID pandemic. I call it the panty. That's what I call it. But so can COVID affect your kidnees?
It can. And
I thought you were going to say no. I was not prepared for your response. I don't have a follow-up question. I thought you were going to say no. Well, tell us how. Tell us.
So, it's interesting because as much, particularly early on in the pandemic, as we talked about, are we going to run out of ventilators? And that concern, I think for those of us who are kidney physicians, we saw that the problem we were having was the frequency of kidney injury, of kidney damage related to COVID. So COVID looks like it can directly cause damage to the kidneys. We've demonstrated that you can find the coronavirus in the kidney tissue itself.
Really?
It can, and we know that. So we know that you can get acute kidney injury directly from COVID.
Okay.
And we know that of people who are likely to have severe kidney outcomes from a lot of damage or sometimes requiring dialysis related to COVID infection are particularly in people who don't have perfect kidney function to begin with.
Well, what's considered perfect kidney function, though?
Well, so people who have normal kidney function. And we might say, the people who have, say, stage 4 and stage 5 kidney disease are at highest risk, and 3 a little less. And then perhaps importantly, as we think about the consequences of COVID, when we look at what are the risk factors for being hospitalized or dying from COVID, well, those are chronic kidney disease, diabetes, high blood pressure, obesity. And from our talk, you can see if you're a overweight diabetic, you almost certainly have high blood pressure. A third of those folks are going to have kidney disease. And so having kidney disease, you may come into this pandemic with, 3 or 4 risk factors for not doing well.
Right.
So it can
already,
right? And we know that because of some of the work we do and being essential workers in many cases, and geography and so forth, we know that African Americans are among one of the groups that are at highest risk of getting COVID.
Yes.
So combining that with risk for poor outcomes, it can be a challenge, for our community and for a number of other communities, as well. The Native American community, for similar reasons, has been hard hit by COVID.
Okay, and so COVID can have a direct correlation or a direct impact on kidney function. So has any research shown that the COVID-19 vaccine can affect kidneys in any way, negatively or positively?
It looks like the vaccine so far, the Moderna vaccine, the Pfizer vaccine in particular, the Johnson & Johnson vaccine also, which is early, all seem to be very safe, very effective, no negative kidney effects. Some people have some side effects from the shots themselves, but it seems like they're protective, in the 91, 95% effectiveness, and that effectiveness is reducing 91 to 95% effective in reducing the chances that if you get COVID that you'll require hospitalization.
Well, that's great news to know that, the COVID, the virus, can affect kidney function, but the vaccine, currently it's no research showing that it can affect your kidneys or any other organ, from what I'm seeing. And, I don't really, my whole point of pointing out COVID-19 vaccine with kidney function is because I think it's really important that we normalize vaccine hesitancy. Vaccine hesitancy is not a bad thing. What is a bad thing is if you're hesitant to get vaccinated based off of false information. So we really want to encourage people to get educated by reputable sources or people, and make your decisions based off of the accurate data that is out there. So thank you for letting us know that from you as a nephrologist, from what you've seen and what you've heard and researched and saw for yourself, that the COVID virus will affect your kidneys, but the vaccine is not shown to have any detrimental effects.
No, perfect. And I think that's absolutely right as we talk about vaccine hesitancy. In some sense, we would say we have good reasons to be hesitant about a variety of medical care. I mean, there's a long history of really good reasons for us to question stuff. Having said that, we are, as we talked about, we're at particular risk for not doing well with this disease, and these vaccines are safe. So I would certainly encourage everybody both to get vaccinated, but also to have that conversation. I've had a lot of conversations with my patients, to say, look, Don, this vaccine, and we just talk through it. We'll talk through everything from how rapidly we created these vaccines, to I'm not sure I really want to go first with this, on and on. And I think we if we want people to be protected, then we need to take the time to really have those conversations.
And encourage you're a doctor-patient relationship. But I think also, like you said, our community also has reasons to mistrust the medical community in general. So it's also about building that trust up with people and your patients and your doctors, and just having those conversations, letting them know what you're afraid of, letting them know what concerns you have, so they can help you make the best decision for yourself. Now, so which leads me to ask too, is it being recommended that kidney transplant patients get the COVID-19 vaccine?
It is. Obviously the direct trial data is a little limited, but in general, we want our patients fully vaccinated. So if you were going to come one place and end up fully vaccinated, that is the transplant. With COVID, in working with our infectious disease colleagues, looked at it, and in transplant, our transplant patients are particularly high risk. For getting COVID because of their transplant anti-rejection medications. And so we both encourage all of our patients to get vaccinated. And at this point, a number of our patients have been vaccinated successfully, really without any trouble. And actually, interestingly, I think for in terms of transplant public perception, there happens to be a physician who there's a transplant surgeon who also happens to be a transplant patient. And he did some publicity when he got his vaccine, just showing, hey,
the proof is in the pudding. That's the best evidence, though, isn't it? It's like, put your money where your mouth is, right? I think a lot of times,
you want to see somebody.
We underestimate the power of people actually, showing that they're doing what they're telling us to do, because it's easy to say, oh, well, go do this. And you're behind the scenes like, I'm not doing that. So, I've been really encouraged about that, but also really wanting to make sure people know that, we shouldn't shame or criticize people who really are looking for more information about the vaccine. And so I actually coined a new term. It's called vac heavy. I'm gonna put that on a shirt.
There you go.
I'm gonna send you a shirt. Yeah, I'm gonna send you a shirt.
Yeah.
I want you to wear it. It's called vac heavy, because I think it's okay to be hesitant. And like you said, there's so many cultural implications about being hesitant and other reasons people may have to be hesitant. But hesitancy doesn't necessarily mean, defiance or complacency. Hesitancy, we're human, right? This is new. COVID-19 was new. Everything is new. Lockdown is new. Everything is new. It's getting old. I want to go outside and I'm tired.
Breathe.
I'm ready. I'm like, oh my goodness. It's like months and days are now the same. I don't know, but I'm glad we were able to kind of get that directly from you, because I didn't know if the vaccine had shown anything in the kidney. So that's
it's been good. It's been good.
Let me ask you a random question.
Yeah.
Can you drink too much water and like mess your kidneys up?
So the general answer is no. If you have normal kidney function, almost no matter how much you drink, your kidneys are just going to get rid of the excess water. You'll end up in the bathroom a lot, but your kidneys can put out water faster than you can drink it. If you have, it's slightly different answer. If you have kidney disease and your kidneys, in fact, can't perform normally, then we do, as time goes on, have to have some limits on what people drink, particularly with really advanced kidney disease.
Got you. Okay. I feel like the older I get, I'm like, my bladder ain't what it used to be. Ain't nothing what it used to be.
No, I was going to say, that's just wait. So,
I'm 25.
Right. Just wait.
I like to say that, but you know. So, okay. So this has been an amazing talk. And I really hope that, we were able to provide some inspiration and information to all of my hood scientists out there. And Silas, you are officially a hood scientist. I thank you so much for taking this time out to speak to me and the community. And I hope we can speak again about all of the other things that you do, such as the participation with MOTEP and just all the things that you are passionate about. So thank you for your time today.
No, thank you so much for the opportunity, and I hope people learned a little bit and that we help answer some questions for people.
Me too. Well, until we meet again, my hood scientists, stay tuned for the next episode being posted on this YouTube channel. Ciao.